Well, hello students. This is Dr. Jim Mitroka, and for our Basic Pharmacology course today, we'll be going over the second part of Chapter 1. So here are your learning objectives, and we're going to concentrate today on the idea of an agonist and antagonist in terms of drug characterization and drug dose response curves. This all falls under the general concept in pharmacology idea, okay? And so specifically, you might ask, well, what is the site of action of a drug? When we talk about, for example, a drug for hypertension, well, it might be working on the heart. That's the site of action, all right? Then the next thing would be, what's the mechanism of action? How, on a molecular level, or at least on a cellular level, is the drug producing its effects? So the mechanism of action, again, for, say, a drug that's for hypertension or high blood pressure might be what we call a beta blocker, which is blocking certain receptors on the heart. And I know I'm getting a little ahead of myself. We'll talk about the details of each of these things as we go along. And we have this receptor site, which is basically the macromolecular unit that the drug is working on. And typically, that's within or on the surface of a cell. And receptors are very specific. It's kind of a lock and key idea with a specific receptor interacting with a specific drug or class of drugs. So these drug receptors are specialized target molecules, as it says here, and in a general way, any molecule that interacts with a particular receptor is called a ligand. Okay, so ligands bind to receptors. Now I have this question here, which I would, if we were in class, I would ask you guys as students, but it's very important to understand this. Why do we even have drug receptors? Certainly, we weren't designed or certainly didn't evolve to have these particular macromolecular units in our body waiting for some kind of a drug to be made to interact with the receptor. They're there primarily to interact with what we call endogenous substances. So most drug receptors are really interacting with endogenous compounds. For example, getting back to my beta blocker idea, epinephrine, norepinephrine are neurotransmitters or neurohormones that go throughout the body, and when those that involve the receptors on the heart are the ones that we could take advantage of and target for drug ligands, okay, that interact with those receptors. But it's interesting, whenever you find a receptor on the body, the first question should be, what is the endogenous substance that those receptors are there to interact with? Now, there are different receptor types, and I just want to go over this briefly. This slide is not taken from your book. There are a few that are just grabbed basically from the internet that I know satisfy the question here. And the question is, well, what are the classifications, if you will, of drug receptors? So we have these three types here: ligand-gated, G protein coupled, and catalytic, that are extracellular. Okay, these are embedded within the cell membrane, right? And then we have intracellular receptors that wherein the drug would penetrate the cell membrane and get within the cell. Typically, that might be an enzyme within the cell, or the compound would even get through to the nucleus and affect gene expression, okay? So that's the intracellular. Now, going back to these three extracellular type of receptors. Let's take a look at them briefly. Okay. Well, we've got ligand-gated, wherein the drug would bind to the receptor and allow for an ion, for example, to go through. Okay. And then we have these G protein coupled receptors, which involve a receptor that is coupled to something called a G protein. Okay. And these are very, very common type of receptors. Most drugs, I would say, interact with these extracellular receptors, which are known as GCPRs. There are also these catalytic receptors that we're not going to talk about too much for now. So this is just a list for your information of drugs that interact with G protein coupled receptors. As you can see, there's quite a number of them. And this is still a very active research area because there are a number of GPCRs that would make good targets and are still out there to be taken advantage of. Now let's take a look at the three different types of receptor ligands. Okay, so here we have on this little table the ligand and whether it binds to a receptor and what it does when it binds to the receptor. Now, it almost goes without saying that all three types bind to the receptor, or else they wouldn't be ligands. By definition, compounds that bind to a specific receptor are ligands. Now, a compound that's called an agonist is a drug or an endogenous substance that binds to the receptor and activates it. It makes something happen. An antagonist, on the other hand, is a compound, a ligand that binds, but it does not activate the receptor. Okay? It's kind of neutral in that sense. Or if there's an endogenous compound around that activates the receptor, an antagonist will actually block that action. And then we have a partial agonist. That's a drug or an endogenous substance which binds to the receptor and partially activates it. So let's take a closer look at the idea of a full agonist versus a partial agonist. Well, what we have here, first of all, to understand is what is called a dose-response curve. So here is drug concentration, okay, in, say, plasma versus the extent of an effect that a drug is causing, all right? And in this case, let's start with a full agonist. So as the drug concentration goes up, as you might expect, the effect increases, okay? And overall, this is important to notice that it's kind of an S shape or a sigmoidal kind of curve, okay? So there's a maximum effect, a ceiling effect that the drug can have, for example. And in the mid portion, you can almost say that we have that the effect is proportional to the dose. All right. So generally speaking, in the midsection, the drug effect is proportional to dose, but at the two ends, not quite. So here is a full agonist, and really, its significance comes to play when we compare that to another drug that's a partial agonist. On the right, we see drug concentration again versus effect. But here, we're comparing the full agonist, which has a ceiling effect here called 100%, and a partial agonist, which maybe reaches only 60% of the full agonist. Okay? So these are, again, two different drugs, one being the full agonist, one being the partial agonist. So let's ask ourselves these questions. Why are these two diagrams not technically dose-response curve. They're called dose-response curves because we're not actually looking at a dose. We're looking at drug concentration. Okay, and I just want you to be aware that there's a kind of a leap between the dose you give and the concentration. Normally they're related. We're going to talk about this more later when we get to the ADME portion of the discussion in subsequent lecture. But for now, you could either call this drug concentration or you can consider it dose. We're kind of considering those things to be interchangeable at this level of our discussion. Okay, so this is a curve like this is often called a dose-response curve, although technically it's a concentration versus response curve. Second thing is, what is the relationship between concentration and effect? As we already talked, as one goes up, the other goes up. And now here's an interesting question. Why might a partial agonist be better than a full agonist therapeutically? So let's say we have a full agonist here, which is morphine, and we have a partial agonist here, which is buprenorphine. And they have different levels of pain reduction. Morphine has a much stronger ability, a much higher ceiling effect to reduce pain than buprenorphine. So you might wonder, well, why would we ever give a patient buprenorphine when they can have morphine? Well, the other thing that goes along with the effect generally is the side effect. It goes in direct relationship. So the side effect of these opiates is respiratory depression. So morphine given at a high dose can actually end up causing death by respiratory depression. Whereas buprenorphine, since it has a lower ceiling effect, therapeutically, pain-wise, also has a lower potential to cause severe respiratory depression. So sometimes a partial agonist is actually better therapeutically than a full agonist, even though that is kind of counterintuitive. Reviewing these terms and trying to put them in a little bit more practical use, agonists are drugs that produce an action and often simulate the action of an endogenous molecule. Antagonist drugs then are inhibitory or blocking, and they typically block the action of an endogenous molecule. Another set of terms that often come up when we're talking about drug action, especially when we're comparing two drugs, is potency and efficacy. Now, typically people get these mixed up all the time, but it's very important that you, as students in this course, really are clear on the similarities and differences. They both relate to drug action. But efficacy is the extent a drug can produce a response, okay? The maximum response a drug can produce, okay? For example, a drug that's morphine again, compare morphine, say, to aspirin in terms of pain relief. Clearly, the morphine has a much stronger effect. That would be more efficacious, okay, at any dose, okay. No, you cannot give enough aspirin to reach the efficacy or the maximum effect that morphine does. Now, potency is the dose required to produce a particular effect, such as the effective dose 50, ED50. So let's look at our curves here. We have one drug here, okay, A, that has a good efficacy, high efficacy. B has a good efficacy as well. And C has a lower efficacy, all right? Now this may well relate to the partial agonist issue that we spoke about later. Could well be that C is a partial agonist and A and B are full agonists. but we're talking about a separate phenomenon here in terms of efficacy and potency. All right. So the question is, in terms of potency and efficacy, how do drugs A and B compare? Well, A and B have similar efficacy, okay? But now catch this, this is a little tricky. A will produce a given effect, say we're looking at the ED50, okay, the effective dose for half. That goes here. This would be the drug concentration or the drug dose is lower than it would be for B. So A is more potent than B. Same efficacy, different potencies, right? It takes less of A to cause the effect than it does B. How do drugs A and C compare? Well, clearly, the efficacy of C is lower than that of A, all right? Efficacy is lower. And one could try to compare potency, but in a sense, when we're talking about drugs that have different efficacies, really it doesn't make a lot of sense to compare potencies. I suppose if you really wanted to say, what is the dose that causes the ED50 for A versus the ED50 for C? You could say A technically is more potent than C because the ED50 is reached at a lower dose. Just to drive this idea home a little bit better, here is a diagram which is from your book. They do a decent job explaining it, but they really only talk about potency and efficacy and dose response in very, very short terms, and it's a critically important concept for you to get. So here's, now in this case, we are talking about dosage, okay? Whereas in the past we're looking at concentration, but we're considering them to represent the same thing. And here's response. So here's drug A, which has to reach the ED50 here is a lower dose than for drug B. So these drugs, I hope you can see here on your own, drug A is more potent, but both are equally efficacious. All right, now we're going to move on to the idea of antagonism. When one drug blocks the effect of another drug, or more likely blocks the effect of an endogenous substance. So here are three little cartoons that I pulled off the internet, which kind of describe that. When you have an agonist, it activates, it interacts with the receptor, it causes an activation. We have an agonist and an antagonist both present at the same time. For example, an agonist being an endogenous compound and an antagonist being the drug. You see they compete for the receptor and you get less activation. And then you can have just the antagonist working, which you'd get no activation at all. So in general, drugs do this antagonism or antagonistic at the receptor site in a reversible way that we call competitive antagonism. Let's take a look at this figure here and see if we can kind of make some sense of what this means. So here, if we have a receptor agonist, something that activates the receptor, and then we look at that versus the effect. Well, for example, let's call it epinephrine and norepinephrine, one of these neurohormones that activates the beta receptors of the heart, causing the heart to go faster. Well, as the concentration of that neurotransmitter or agonist at the heart goes up, we see that we get a faster heart rate, for example, right? That would be expected. Now, in the presence, however, of a competitive antagonist, the concentration of the norepinephrine at the receptor site would need to be higher to cause the same increase in heart rate. Okay, so a competitive antagonist is basically blocking the action of an agonist or endogenous substance. Kind of makes it, as the diagram here says, it makes the agonist look less potent by shifting the dose response curve. Now, there are a handful of drugs, not many, that act in an irreversible way. They're irreversible antagonists. Okay, and this primarily occurs when the antagonist binds covalently or irreversible to its receptor. And it makes the agonist look less efficacious by reducing the maximum drug effect. In other words, it's taking the receptors out of the picture by binding to them and tying them up, okay? And so here again, kind of comparing this figure to the previous figure, if we talk about an agonist alone, here's the agonist concentration, okay? Agonist alone. You see, for example, norepinephrine stimulating the heart. Here would be the concentration that would stimulate the heart half maximally. Now, when an antagonist is their irreversible antagonist, it actually pulls those receptors out of the picture. So now, no matter how much of the norepinephrine is there, the ceiling effect is reduced because the number of receptors themselves have been reduced. Hope that makes sense. Now, I asked the question, why are very few drugs developed that act irreversibly? I hope you could think about this and see that irreversibly means the action, the antagonist action, continues even after the antagonist drug has been cleared from the body. That is the unchanged antagonist drug, because the drug itself, a few of the molecules have bound irreversibly to the receptor, and the action, that irreversible action, will not go away until new receptor is synthesized. All right, I hope that makes sense to you. So there really are only a handful of irreversible antagonists because it's very, very difficult to control the action. If someone is given an overdose, then there's nothing you could do about it for a long time. So I wanted to give you one example of such a compound because it's rather common, right? And that is aspirin. Now, aspirin is a very complex drug, and it has many, many different mechanisms of action. And believe it or not, compounds can have different mechanisms. But one of them is that it is what we call a cyclooxygenase inhibitor. Cyclooxygenase is an enzyme that normally takes arachidonic acid, which is a major component of virtually all membranes, and converts it to this. You see the cyclic oxygen here. The cyclooxygenase converts arachidonic acid to these nasty prostaglandins that cause local inflammation. Okay, so you hit your finger and it activates the prostaglandin synthetase here, the cyclooxygenase, which converts the arachidonic acid to prostaglandins like G2, and that causes pain. Well, what does the aspirin do? This is fascinating. Here's the molecule of aspirin, and this is an acetyl group on the aspirin molecule. That's why it's called acetyl salicylic acid. And what happens is the aspirin actually loses its acetyl group. It transacetylates with a serine hydroxyl of the cyclooxygenase. So the enzyme itself becomes acetylated. Okay, that is for all practical purposes, an irreversible covalent binding type of interaction. So now you've got the enzyme which is inactive. Okay. And again, this is just part of the action of aspirin. I know aspirin doesn't last forever. The effect doesn't last forever in the body, but in some ways it does. And maybe we'll talk about this later in the course. And kind of a little bit of a teaser for our next time we get together is we'll be taking a look at time versus plasma concentration curves. So far we've been looking at concentration versus effect, or what we call dose response curves. Those are very important, all right, but that's independent of time. Now we're going to look at, or next we're going to look at the effect of time and how that affects the concentration of drug and how that relates to the therapeutic and toxic action. Okay, that's it for now. Take care, my friends.